I repeated the case for the benefit of others who came late. Okay, we can start now.
Should
Keep
I
the
start
time and
now?
start. Dr. Adnan, you can start.
Yes, you can start now.
Okay, start.
Good afternoon. I believe I'm talking to Mrs. Colin.
Yes, doctor, this is me.
Hello.
Yes.
Yes. My name is Dr. Bindia, and I'm one of the pediatric registrars.
Yes, doctor, go ahead. Why there's any connection problem? Hello?
Yes, we can hear you, Dr. Liu. In this hospital.
Good morning, doctor.
I believe I'm talking to Colin, Krisa's mother.
Yes, yes, doctor, I am Colleen.
Nice meeting you today. So, do you have I understood that you have some concerns regarding Krisa's health. So, I just wanted to know details about it. I'll just take some notes as well. Okay, is that fine?
Yes, doctor, no problem. Go ahead.
Okay, please elaborate on your recent concerns on Krisa's health, Colin.
Actually, doctor, her weight is getting reduced day by day, which is making me more worried. She was a very good girl. Now she's 13 years old. When she was 9 years old, she was a very good girl, and her weight was on 50th centile. Now suddenly, over a period of 3 to 4 years, she's every year falling in her weight.
Okay.
Up to 11 years, she was fine in the same centile, but over 2 years now, she's gradually falling in her weight. This is making me more worried.
Okay. So, apart from this constant decrease in the weight, anything else have you noticed, Colin?
Yes, doctor, she's not sleeping well. This sleep is from 6 months, I can say. Before 6 months, she was okay. She's not sleeping much. She sleeps only 3 hours when she's too much tired. Otherwise, she always sits in her room and with her mobile and just like that. She's not doing anything.
Okay. Is she increased in her activity levels? Anything you have noticed?
No, actually, her activity levels are decreased. She's not playing like before.
Okay. She's complaining of tiredness as well?
Yes, doctor. Yeah, because she's not eating. She's not eating anything. That is.
Okay. She's refusing her food, or she's telling she is not hungry?
Actually, I give her food, but she says that I am sick, I don't want to eat. And then maybe she'll take 1 or 2 spoons, and then she prefers to take more fluids, especially water.
Okay. Is she vomiting after food?
No, no concerns about vomiting, doctor.
Okay. Have you noticed her any behavioral changes associated with this?
As I told you, from 6 months, I hardly see her playing. I hardly see her meeting any friends. And she prefers to be alone. And also, I see her that sometimes she has injured herself, which is making me more worried. Like I see some marks on her legs. Then I am cautious now. I keep seeing every day. I look at her 3 times. I go to her and check is she not harming herself. This has made me more worried.
Okay, I understand it could be causing much worry for you. Have you noticed any abnormal movements or any complaints of any headache or vision issues for her?
No. Sometimes headache is there, but I cannot say that it is to the extent that it is creating any problem for her. No
Okay.
abnormal movements.
Okay. How is her dental hygiene these days? Is she complaining of any toothache, or
No.
she's okay with her dental part also?
No.
Okay. She's fine with her dental part, right?
Yes.
Okay. So is she telling she's having any fast breathing, or difficult to breathe, or
No. No breathing problems. No cough. No breathing problems.
okay. So how is her pee and poop these days? Is there any changes? Any constipation, diarrhea?
Actually, she's not passing the poo daily. I cannot tell it as constipation, because if she passes normal. Maybe she's not passing because she's not eating. She passes every 3 days once, like this. Otherwise, pee, she's taking enough water. She passes lots of pee, no problem.
Okay, she's drinking more amount of water than previously, or she's drinking just enough as previously?
As previously, I can say a little more, because she wants to kill. This is my feeling. I am not sure. I feel that she don't want to eat, but she feels hungry. So she wants to kill her hunger with water. This is my thinking.
Okay. Is she complaining of any generalized body pain or muscle pain? Anything? Have you noticed?
Yes. Body ache is there. Body ache is there, but it's okay if she relaxes, and she'll be fine.
Okay. So now she's 13-year-old. Has she started to have her periods, menstrual cycle?
Yes, when she was 7 years, she got
Sorry.
her periods. Yes,
Okay. She's
but
getting it.
now from no, but now from 5 months she did not get her periods.
Okay. So, is there any fall of hair, or skin becoming very dry? Anything? Has she complained about it?
Yes, there is fall of hair. Yeah, I can see obvious. She did not complain to me, but I can make out that there is fall of hair for her.
Okay. How is otherwise things at home, Colin? Is everything fine? She's okay with her siblings. I know she's tired, but she's managing well with her siblings and you.
Yeah, earlier she was playing with her siblings, but now she doesn't prefer. She prefers to stay alone.
Okay. So all of you are staying together. You and Christy's father. Everybody is together, right? There are no issues at home.
No, doctor. We are separated.
Mhm.
From 2 years we are not together, and actually the reason is it is one of the reason is I have gained weight, and the father was not happy. Maybe this has created some problem for her. I am not sure.
Okay. So you feel she's worried and sad about this?
Yes, doctor. Actually, I did not tell this to anyone. I'm just telling you this to you because this is my thinking. Maybe because the father left us, one of the reasons is the increased gaining in weight in me. Maybe she's worried that she should be more thin or something like this. This is my feeling. And also she expresses that despite being so thin, she says that I am fat. I don't want to be fat anymore, like this.
Oh, she might be worried about this. How many siblings has she got?
She has two siblings, younger to her.
They're all fine, right?
Yes, they are fine, doing fine at schools. Everything is fine.
Okay. Are you working, Colin?
Yes, doctor, I have to work because I have 3 children. I have to earn for them. Yes, I am working in an office.
Okay. So they're looking after themselves, your kids, when you go for work, right?
No, I take some help from my neighbor. She's one of the good friend of mine. She takes care sometimes for few hours when I go for work. But usually I see to it that I finish my work fast and get back home.
Oh, that's Fine. So how is she at school? Teachers have complained anything that she's not listening, because I understood that she has a reduced performance in school these days.
Yes, till 11 years, her performance was very good. From 2 years, gradually the performance is decreasing. Nowadays,
5 minutes. 5 minutes left.
okay, 5 minutes left. From 6 months, I am getting repeated complaints from the teachers that she's not doing her homeworks, and she has some issues with her friends. She's fighting and sometimes shouting, not
Mhm.
mingling with them, like this. So I met the teacher as well. She told that she needs some assessment. That's why I'm worried, and I went to the GP couple of times. He did some tests, and he said whatever tests he did was normal. I am not sure what tests he did. Then when again I went for the third time, he referred me to you.
Okay, fine. So is she missing the school very often?
No, not very often, because I am very strict, because as I told you, I go to the office. So what I am doing is they go to the school, and then the 2-3 hours which after they're coming back from the school, my neighbor will take care. So I
Okay.
don't believe in missing the schools. I see to it that they go regularly.
Okay, fine. So you're a keen mother. So is she allergic to any medications?
No, doctor.
So in what all medication she is on now? Is she on any medications?
Actually, no. No, she's not on any medications. Only sometimes if she gets headache or body aches, and if she's not relieved by rest, I give her paracetamol.
Okay, so how she used to tell everything to you, because I need to ask some personal question if you don't mind. So is she started smoking, or whether she's taking alcohol or something?
I think no, doctor. Never I smelled any smoke or alcohol from her, and even in the from the school, I did not get telling me anyone. But this self harm she has started recently, which is worrying me more.
Yeah,
Otherwise, I don't see any bad habits with her.
okay. And has she told about any special relations which she's having these days?
No, no special relations. Actually, I feel more than mingling socially, she is more alone.
Okay, so all the tests which GP did was normal, you told, right?
Yeah, actually, he told it's normal, but I don't know exactly. Maybe he forwarded to you also. I'm not sure.
Okay, so I'll just get into the details of that. But was she admitted previously because of any illness, or she had any surgeries or any
No,
significant illness?
no admissions. She was a very good, well developing girl.
Okay. During the birth also she was all fine, right?
Yes, birth was fine, no issues.
Okay. Has her all jabs done?
Yes, doctor, done.
Okay, fine. So do you know what tests have been done on her so far by the GP?
No, doctor, he said some tests, but I don't remember, because I am a working lady. I have to concentrate here and there. It went out of my mind. I am not sure what he did.
Okay. So basically you were telling she was only having most of the fluid kind of diet, and solids she was not taking. So is there she has any fainting attacks or lightheadedness because associated with this?
As such, no fainting attacks. As I told you, she likes to stay in her room on her bed most of the time. So she did not feel anything. Only thing is she does not want to eat carbs. She tells clearly that she has gained more weight, despite now she is below the 9th centile. The GP showed me her chart by plotting it. He said that she is below 9th centile in her for the body mass index, he said, which I don't know exactly how they calculate, which is low for her, he told.
Okay, so it was nice talking to you, Colin. So we have discussed about Krisa and her concerns which you have on her health. So is there any other thing which you have to tell me apart from what we discussed today?
Nothing, doctor. Only I'm too much worried because she's losing weight and there is some issue of self-harm. I don't know how she will come back, and nowadays she's not getting her periods from 4 months. So I'm worried.
Time over.
Okay, thank you.
Okay, Dr. Deepa,
Deepa,
present your
present.
case.
Yeah, I have taken history from Colin, mother of Krisa, 13-year-old girl who is having a decrease in the weight over 3 to 4 years, and also 6 months of decreased activity and sleep associated with poor school performance. She has a history of self-harm and a social and the family history of parents being separated, with father complaining of mother's weight gain and bodily appearance. Otherwise, she does not have any significant past history or birth or immunization and developmental history, everything being normal.
Okay. Any negative histories you want to add?
Yes, she does not have history related to the significant systemic illnesses, and also any endocrine issues, and she's also having no menstrual period since 5 months.
Okay. So what is your differential diagnosis for this patient?
From the history taken, I would like to consider anorexia nervosa as a first cause of the diagnosis. Also, endocrine causes like hypothyroidism can be considered. And
What, hypo or hyper? What you said?
hypo, I told. Hyper, sorry, loss of weight. So hyper. And it could be behavioral disorders. Depression can also be a cause. And we also have to evaluate for chronic systemic illnesses.
Okay, with the history, you think it's anorexia nervosa, and depression can also be the second cause. Third is the hyperthyroidism. Okay,
Yeah.
These are your differentials you are putting. Did you ask anything in the history to rule out hyperthyroidism?
Just asked about the activity level, which she was less active, and there is a hair fall. But a cold and heat intolerance, I didn't ask. But from the other history I got, it does not suggestive of hyperthyroidism, is not a cause.
Yeah, you have to ask mainly for the cold and heat intolerance, and also you have to ask about the heartbeat. Means anytime she complains of awareness of heartbeat. Okay, this you did not ask. Hyperthyroidism, you can when you are in the history, you can just ask for this heat intolerance and awareness of heartbeat.
Okay.
So why do you think this is anorexia nervosa? What else suggests in the history that this is anorexia nervosa?
One main positive factor which points towards the anorexia nervosa is the parents got separated 2 years back because the father was complaining the mother was gaining weight, and this appears that she has been disturbed with this, and she also was scared in gaining weight from the history I took. So this is one reason, and she has associated self-harm behavior also, which could be the consequence of this anorexia nervosa, and she was mostly taking a fluid diet to decrease the weight gain and reduce on the carbs.
Okay. So what investigation, okay, how do you want to proceed with this patient now?
So after being taking a history from mother Colin, I would like to talk to Krisa alone and to know better about her and her issues, and also to do a physical examination, including a BP, heart rate, temperature, to know the severity of her illness. Then also to do a detailed systemic examination. So after that,
in BP, if
hello?
this is anorexia nervosa, what can be your finding in the BP and heart rate? Any findings you can have?
Yeah, there will be a chance of bradycardia, and if it's a very severe form, arrhythmias also can happen. BP will be low, and even there can be postural hypotension as well.
Okay, BP can be low and postural hypertension, and sometimes even you can also see the tachycardia also if they are not very severe. Okay.
Okay.
Investigations.
I would like to see her full blood count and blood filling. We have to rule out anemia and also serum electrolytes. There's a chance of hypokalemia, hyponatremia. Blood glucose has to be checked. Then other tests which I would do is the magnesium, calcium, vitamin D, and urea creatinine to rule out chronic kidney disease. ECG will do. ECG to rule out bradycardia or arrhythmia.
Okay. So in the investigations, you said FBC and electrolytes, right? And blood sugar.
Yes.
And renal functions. That's all. Anything else you told?
The thyroid function test also I would like to do.
Okay. Okay. In this case, you will do full blood count, electrolytes, including calcium, magnesium, and you have to do and even phosphorus. You have to do the blood glucose, renal function test, thyroid function test, liver function tests also, and vitamin D level, she said, and ECG monitoring.
Yes.
So how do you want to treat her?
If she is having like a condition associating with her vital signs like a low heart rate, BP and all, I would like to admit her for the further management. Then I'll be involving my consultant and also the physician who is specialized in the adolescent eating disorder. She requires a psychiatrist help as well to talk to her, and a psychologist to talk to her about her behavioral issues and sort of the self-harm behavior. Then I will involve the dietitian to know about her diet intake and to start the refeeding. And a social worker and school teacher also can be involved.
Okay, so psychological support, you can tell like the psychological support, school support, social support, and even an health visitor should visit them often. Okay. So can you tell something about refeeding?
Refeeding has to be if the child is able to take orally, oral feeds can be given. But in case if they are not able to take orally, nasogastric tube feeding is given. So basically, it will be to replace the calories and to increase the weight, at least 1 kg in a week. So there will be mainly 3 main meals and 3 snacks in a day. And we have to monitor for the refeeding syndrome as well.
Okay, what you have to monitor in refeeding syndrome?
Basically, the phosphorus level, then potassium, phosphorus, all serum electrolytes with thiamine level also we need to monitor.
Okay.
What
Anything?
what will happen with them in refeeding syndrome?
All this phosphorus, magnesium, potassium, and thiamine can cause a drop in the this thing drop while during there is a refeeding syndrome. So you can supplement all these things. And the child also can complain of bloating sensation, persistent vomiting, also when there is a refeeding syndrome, when we start so much of food at a time.
Okay.
Okay. Anything else? You missed one important point. Apart from
Endocrinologist.
Psychological support, school support, social support.
Endocrinologist also can be involved because that first we'll see whether this is getting sorting out with her proper food intake and assessment initially. If this is not getting settled, I would like to do endocrinologist opinion and also do the hormone levels of her this thing.
One more, anyone can add the one important thing in management she is leaving? Anyone?
cardiologist?
Actually, there should be psychiatrist and psychologist also for the cognitive behavioral therapy community
Yeah, you
team.
have to mention this psychiatric and psychologist for the cognitive behavioral therapy. This has to be mentioned, okay?
Community pediatric.
And this CAMHAMS.
Yeah, child and adolescent mental health services to be involved, and family based therapy has to be initiated involving the family members, and we have to sort out the mother's concerns and stress in their family as well as in treating CRISA.
Yeah.
In this case, suicidal ideations should be asked because there was a history of self-harm. So we have to ask about the suicidal ideations as well.
The age of the girl is
13
13.
years.
13. So heads protocol like house life, education, activity in sports, drug, alcohol, smoking, and sex, suicidal tendency.
Yeah. So in main, tell about the cognitive behavioral therapy, okay?
Okay.
I want to ask Dr. Adnan, what is the difference here in the psychological and psychiatric support in the psychologist and psychiatrist? What difference in their roles? Is there any difference?
Yeah, psychological is mainly for counseling, psychiatric is for drug treatment.
Okay, so there are some, now she can be in depression as well. Do we treat the depression?
No, actually, here I will tell you in the psychiatrist, if she's having some psychiatrist problem like in anorexia nervosa, sometimes there can be obsessive compulsive disorders. Then antidepressants can be given. But this I think they are, I don't know, remember this name.
Fluoxetine.
Yes. But in here in this case, especially in this case or anorexia nervosa, the most role of is psychologist. Like talkative therapy, they are doing talkative therapy. They are doing some focused family therapy involving the whole family or carer, and they are doing this cognitive behavioral therapy and adolescent focused psychotherapy. There are so many terms, and they are doing like minimal. They have written that at least in a year 18 to 20 sessions should be there. 18 to 20 sessions, and sometimes they are increasing these sessions till 40 sessions in a year. So sometimes they will involve the family, and sometimes they will do alone with the child.
Yes, so don't
Yeah.
forget to mention with the you are referring to psychologists for what? Mainly is the cognitive behavioral therapy. Okay,
Yes.
use this word. This is this they will be expecting this word, cognitive behavioral therapy.
Dr. Noor, I will tell you there are three words. One is FTAN, focused family therapy associated anorexia nervosa. One is CBT, cognitive behavioral therapy. Other is AFP, adolescent focused psychotherapy associated anorexia nervosa. These three things they are doing, and all sections are doing these. They will do separately from family members and together with the family members. And in the anorexia nervosa, they will not offer, they have written in the guidelines, do not offer any medication at the sole treatment for the anorexia nervosa.
Yes, yes. This antidepressants also will be started by the psychiatrists. Okay.
Yeah,
If they
psychiatrist.
really need, like if they are in more depression, which is not being controlled by these therapies, or any obsessive compulsive disorder, right?
Yes.
Yeah, and along with the fluoxetine, even the selective serotonin reuptake inhibitors,
Yeah, that one can be added.
SSRI and fluoxetine, but we need, they don't need expect you to tell the names there. They want you to what you will do for her depression.
Yeah, for that, yeah, you will say like that. First, I would like to assess her physical health and physical activities, including any physical effects of malnutrition or any compensatory behavior, such as she's maybe doing inducing vomiting or using these laxatives. So this is all are coming in the mental health problems. For that, if there is any mental health problems like depression, anxiety, like here in self-harm is there, or any obsessive compulsive disorder. So all of these, first I will like to uh, figure out. Then I will involve the multidisciplinary team that will involve like pediatrician, my consultant, psychologist, psychiatrist, dietitian, and community team, endocrinologist, and what else? This, if the child is having some electrolyte imbalance or having some arrhythmias, so would like to involve the cardiologist as well in the initial phase. And I would like to involve the occupational therapist and rehabilitation therapist. And there will be definitely mental health nurses and the dentist. Definitely, all these will work in a community team, and there will be a kind of coordination between these professionals. So you will have to
So
tell this one.
yeah, so we will tell the multidisciplinary team, apart from what Dr. Deepa said, we will also add if there are any deranges in the ECG, you will also involve the cardiologist and
Sorry, I'm disturbed. Somebody asked why you want to involve the occupational therapist. Sometimes they are doing this for the home modification because he's self-harming. So for that, we need to do some home modifications, and may we need because now she's self-harming. Maybe she's having some suicidal thoughts in her mind. So for that, you'll have to do some more home modification. So this is we call occupational rehabilitation therapist.
yes.
But and suicidal, if the patient is suicidal, doesn't that warrant admission? When do you consider admission of such a patient?
Indication for admission, you mean?
Yeah, sure.
When there is low BP, there is bradycardia, you see some changes in the electrolytes. This is for the refeeding. Okay. For the suicidal, maybe for the to prevent her as a social, right?
Yes, so self-harm is an indication for admission.
Yeah, I think
Yeah,
self-harm is
definitely.
an indication.
Self-harm is an indication for that.
Yeah, the mother told her that she once she got to know that she's self-harming, she keeps her monitoring every now and then to check the self-harm. So self-harm is also an indication for admission.
Yeah. They are using SCOF questionnaires also, but in the guideline they have written that don't depend on alone on SCOF these questionnaires. From the child they are asking if you are make yourself sick because of you feel uncomfortable, or you lost control over how much you are eating. Have you lost more than 1 stone of in 3 months period? You believe that you are fat when others are saying you are thin, and you say that food dominates your life. So these are 5 questions. They are using these tools also in these days, but in the guidelines they have written that don't depend alone on this.
The whole history, the whole background, everything matters.
Yes. So in the laboratory, as you mentioned, Dr. Noor, so this will be like a CBC to rule out anemia. Any ESR you can do for to rule out any chronic infections
Inflammatory.
or their inflammatory markers, like, so there can be a sugar level, then blood chemistries, in the blood chemistries, LFTs, RFTs, serum electrolytes, urea electrolytes, especially albumin. Don't forget, because malnutrition is there. You will have to do the bone profile like calcium, magnesium, alkaline phosphatase, parathyroid hormone levels, and of course thyroid function test. And there are some scans they are doing, this bone mineral density scan, and of course ECG and urine analysis. So all these are the, so
Bone
some
age
are,
as well.
yeah, yeah, that one is bone mineral density scan you can
No,
do.
no, no.
So,
Bone age.
bone age, okay. Bone age, why you want to do bone age?
Because her menstruation is delayed. For last 5 months, she hasn't received. She has no menstruation.
No, it's
So if
not
It's
you're
not
delayed.
No,
it's not
that one
delayed, but
is
it's
secondary,
I mean,
secondary
not
secondary
amenorrhea.
for her.
amenorrhea.
1 minute, I will
That
mute
one is
all.
secondary
One of
amenorrhea,
you
no need of
open.
bone age.
Yes, I muted all. One of you open.
This is actually secondary amenorrhea, so no need of for that bone age.
No,
If
I'm
it
saying
is
in
primary,
general. I'm saying in general, when you are coming with a patient with anorexia nervosa, then you have to go for bone age with bone density scans.
yeah,
It's
Good.
mentioned.
bone density scan,
Yeah.
yes, they have mentioned that one also.
And ESR, I mean, I don't know. I'm just reading from Van Harris, and ESR or anything is like that is not mentioned. Bone age is mentioned.
No, ESR, you know why? ESR is for your differential diagnosis. So let us,
Yes,
I want to tell you why you want to do ESR and CRP in this
I,
patient.
IBD, inflammatory markers. If you're
Yeah,
thinking,
yeah, yeah.
inflammatory bowel disease, inflammatory. You see, you will always keep the differentials. Now, the differential here, along with this anorexia nervosa, depression, hyperthyroidism, you have to consider all, you have to exclude all the cases of all the causes of weight loss.
Yes, this is
And you are
actually
asking
we
the
know.
history.
Yeah,
Yeah.
very nicely, Dr. Noor, you said. Uh, in the beginning, we know that we are studying today anorexia nervosa. That's why we will focus on anorexia nervosa. But all
No,
of a
yeah.
sudden, if you are sitting in the exam and this scenario is came the same like Dr. Noor has given, so we will have to consider why she's losing the weight and she's not, school performance is going down and she's not well enough in sleep. So for that, you will have to make the differential. Go ahead,
Yes.
Dr. Noor. This is very nicely you said.
Yeah. So the reason for all your, always remember how you will correlate your lab investigations is with your differentials. So now the concern for you in the, this was the weight, right? So you will always remember, you have to find out what is the cause of her weight loss. Okay, so when you are asking also the red flags, you have to consider all these things. So here you see differential diagnosis for this is for eating disorders. Okay, consider physical causes of weight loss, including celiac disease. So in the family history, you should ask for the family also, anyone has this similar condition. Maybe someone has weight loss due to some other cause also. Okay, so celiac disease has to be considered, which is the GI cause, and then the Addison's disease, endocrinal cause. See, for endocrine, you have three things: hyperthyroidism, Addison's disease, and diabetes. Okay,
Yes,
then
yes,
never forget malignancy. So when you
yes,
are asking there, she said there is headache, but she told you also very well that it's not disturbing her too much. It's a good point for you. But still, when she said headache, quickly you can ask any early morning headache or vomiting or anything you see with the changes in positions or stressing, straining like this, you can ask for fast. Just to rule out any malignancies like CNS tumors or any bruising in the skin. This was not asked. Okay,
yes,
if you keep malignancy in mind, you will ask the leukemia, even though
right.
we cannot say it's very common, but still you can ask for the bruising in the skin. So keep malignancy in your mind for acute weight loss. Okay, and
Mhm.
also diabetes. There is one more thing which will be confusing you. She's taking more water, I said, but at the same time,
Yeah.
others. 1 minute, huh? Okay, so always keep in mind to rule out these causes of the weight loss, like Addison's disease, inflammatory bowel disease, malignancy. So again, now we will go read this and then we will go to the investigations. Then we will get to know why we are doing this, why we are doing this. Like TFT we are doing for hyperthyroidism. Blood glucose check can be for two reasons. She's not at all taking any carbs. Maybe when she presented to you can be hypoglycemic, and also she's taking more water. We'll rule out the diabetes for you. Then ESR CRP will help you apart from the infections for inflammatory bowel disease, like this. And also you have to do for some nutritional deficiencies like zinc, selenium and vitamin D. So if we go to the
Excuse me, Dr. Noor, sorry to interrupt. So the symptoms has been happening since 3 to 4 years, right? So since that, can we consider malignancy as a differential, because it would have been worsened by that time, and mother told the blood test everything was
no,
normal?
actually the the symptoms is from 11 years, so 2 years, and increased in 6 months.
Okay. So still we can consider malignancy.
Yes, any weight loss, don't forget malignancy. So now we will go FBC, we will go for, we will see, this is the investigations you will tell there. FBC to rule out anemia. U and E and electrolytes, as we know that there can be electrolyte disturbances because she's not taking enough food. Phosphate, magnesium, calcium, all the electrolytes has to be done along with sodium and potassium. Then thyroid function tests for hyperthyroidism. Glucose, two reasons. One is for diabetes, one is can be hypoglycemia. Then if vomiting, you will also check amylase and bicarbonate. Why bicarbonate will be raised in vomiting? Who can comment?
Loss of HCl.
What is that? Hypokalemic and hypocholeremic
This is, this is due to induce a vomiting.
This happens even in the pyloric stenosis, right?
Yes, exactly.
Yeah, that is why you will do
hypokalemic, hyperchloremic alkalosis.
Yes. So bicarbonate may be raised, then amylase. Next is this you will do because she's not taking, she will not take sufficient non-veg or this, or you will lose vitamins also, right? So you will do B12, folate, ferritin, celiac screen. See, here in the causes we read celiac disease has to be ruled out. So in the investigations, celiac screen, ESR, CRP, CPK for any muscles. Then zinc level deficiency, check zinc level. Deficiency leads to altered appetite and may resemble anorexia nervosa. Zinc deficiencies can resemble anorexia nervosa. Then vitamin D, commonly deficient in eating disorders, increases the risk of osteoporosis. Okay. So at least we have to tell this much. FBC, urea electrolytes, LFT, KFT, thyroid function tests. Then you can also add for the blood glucose, and you can say vitamins, multiple vitamin levels, and then vitamin D, and this if there is vomiting, this patient had no vomiting. If the patient which you were taking, there was vomiting, you have to tell this amylase and bicarbonate. Amylase for what? Rule out pancreatitis, you mean? Or any acute
for malabsorption.
Okay.
One of DD is protein losing enteropathy is there also, malabsorption syndrome.
So all these things is this and refeeding syndrome. See, he has given some good points here about refeeding. What happens when you switch to carbohydrate metabolism after starvation? She's avoiding carbs. This was in the history, right? So now suddenly you will give more carbohydrates to her, can cause acute phosphate depletion with serious sequelae. So this is the reason you will be every day monitoring her phosphate along with the other electrolytes. So after commencing feeding in high risk patients, if you think that this patient is high risk and you are admitting for refeeding, you have to do at least daily. This is daily your urea, electrolytes, phosphate, calcium, magnesium, glucose. So you will think that all the electrolytes with glucose you will be doing daily. Don't forget about the phosphate. So anytime you see that the phosphate levels falls, you will give 2 to 3 millimoles per kg per day in 2 to 4 divided doses. Maybe they may not go to that extent asking you how much you will give, but they can ask you what you are afraid of in refeeding syndrome. You can say that there can be acute phosphate depletion and needs phosphate replacement. So daily you will be doing these investigations: urea, electrolytes, phosphate, calcium, magnesium, and glucose. Okay, they have given this. Everyone will read by themselves this red amber categories in the next page. And also this, see, oral thiamine can be replaced to them as 100 mg 8 hourly, and vitamin B. Okay, for a doses they are asking to see the BNF. At least you can tell that you will be giving the oral thiamine and vitamin. But I don't know what is this Pabrinex. What is Pabrinex? Anyone? Okay, no problem. We will find it out later. Okay, so higher risk if BMI is less than percentage of median BMI is less than 70, then there can be who are the higher risk and who you will be considering the refeeding urgently. Neutropenia, minimal energy intake pre-admission, means they have absolutely stopped the carbohydrates. Then what happens suddenly when you switch from carbohydrate metabolism after starvation? He is telling there is acute phosphate depletion. So minimal energy intake pre-admission, previous history of refeeding syndrome. These are all high risk, means previously also she had same problem and you have admitted and you have feeding, and at that time she had phosphate depletion and she has developed this syndrome. So if vomiting or laxative use lead to hypokalemia, supplement with potassium. Okay, these are the important things. Next is the non-medical management, which plays very important role here. Management: beware of refeeding syndrome. If this is a high risk patient with all these characters like BMI less than 70, neutropenia, and all these things, as I told you before, you will be aware of the refeeding syndrome. Then you will monitor for possible concealment of food, interfering with nasogastric tubes, vomiting and laxative use. You will also find out, maybe without your knowledge or hiding the mother, she may use all these things: vomiting, laxative, inducing vomiting, and interfering with the nasogastric feeds. Possible concealment of food, means she will say I will take, but she will not take. And also sometimes they may do exercise too much to reduce the weight, that is overactivity. Manipulating weight, drinking water, heavy clothes, concealing weights. This I told in my patient, she doesn't want to take carbs, so she is killing her hunger with water. Discuss with local specialist CAMHAM's eating disorder team. So you can tell this this in the exam. Aim to build specialist management. This one, Mrcpch group is there. You can also consult them. Okay, what does this group consist of? Psychiatrist, nurse, dietitian, and pediatrician. Okay, this group is made specially for the patients who are sick, really sick patients with anorexia nervosa. See here, they have made this for management of really sick patients with anorexia nervosa, and this team will involve the psychiatrist, nurse, dietitian, and pediatrician. We can tell that this group, under which we will also have psychiatrist, nurse, dietitian, and pediatrician. Okay, early recognition of and treatment of anorexia nervosa improves outcome. Okay, anyone wants to give any comments? Dr. Deepa, you read refeeding from anywhere else? You want to add anything apart from this here?
Same, I just read from the other book now, Wayne Harris. So from there I read. It was just
what they have given?
1 second.
Anything else apart from this? for the refeeding syndrome.
Yeah, I have
They
to
can
just open it 1 minute.
ask about the refeeding syndrome, because which is more common in these patients. Okay, till she opens and tells us some good points. Anyone can tell us about the anorexia nervosa symptoms? What you see in the child? How do you tell that? How do you support your diagnosis that this is anorexia nervosa?
There are so many symptoms can be like loss of weight and
Okay.
maybe irritable, headache, fainting or dizziness episodes, dry skins, hair loss. There can be a relative constipation and maybe have cold and clammy skin, hands and feet. Social withdrawal can be there, or obsessiveness, or may have lethargic, bone pains. All these muscle ache, all these are associated with anorexia nervosa. Any symptoms can be there with the lost weight.
She's
yeah.
thinking herself fat instead of such a weight loss.
So how do you check whether this child is really in this category? One thing is your calculation, okay? So you will know, like for this child for 13 years, what should be her median BMI? It is there in the next page table. This, okay? For our patient, let us see. Her median BMI is 18.8. But what was given for you in the case? It's 9, right?
Yeah, it was 9. Below
That is
9 percentile.
percentile. Yes,
9
Yeah,
percent.
percentile. But if you see the percentile chart, I will share for you in the group. It will come below this. Okay, it's below this. Okay, I will share the charts later in the group. So it should be typically less than 85% from the medium. So you will calculate yourself. Like for example, in this child, 85 by 100 into 18.8. What answer you get? If it is below that, she has anorexia nervosa. Okay, so restriction of energy intake relative to requirements leading to low body weight. Your calculation is based on the BMI. Okay, this you do it for yourself for this child later. Okay, then fear of gaining weight. This I told that she despite of such a low weight, she says that she has fear of gaining weight and persistent behavior that prevents waste restoration. She doesn't want to take carbs and she wants to drink more. Disturbance in perception of body weight or shape. Self-evaluation unduly influenced by weight and body shape. Ambivalence about very low weight. So mainly their mind is always thinking that I am overweight, I have to reduce. This is what you get it in the history. Apart from that, what else you will see is the BMI. You have to remember that it should be less than 85% of the median age. You can tell because you will not tell the exact there. If they ask you what BMI you expect to label them as anorexia nervosa, you can tell that this is the answer, less than 85% of the median BMI for age and gender. Okay, this is one thing. Apart from that, as Dr. Adnan said, rapid weight loss. Then you can see the always anxiousness about that she is fat despite of being thin. Despite being thin, they think that they are fat. This is the thing. Then depression, anxiety, compulsive exercising. They feel that they have to exercise more and more to lose the weight. This is compulsive exercising. And they also have feeling of hopelessness and social withdrawal. Usually they don't mingle, they don't want to mingle with anyone, prefers to be alone. This is social withdrawal. There can be hair loss, irregular heartbeat, and low BP, feeling of fatigue, lack of emotions like this. Okay, lack of energy like this.
In this Wayne Harris only 2 sentences given. That is, it is important to avoid refeeding syndrome during the treatment, which can be very dangerous, and that phosphate, magnesium, potassium, and thiamine can drop to dangerous level. So check these every alternate daily or basis for the first week, and you can give thiamine parenterally for the first 3 days. That's it.
This
And
Pabrinix is also thiamine only, the one which B1. This Pabrinix that you were asked that was written over
Yeah,
there.
yeah.
That is
Okay,
also
yeah.
I think this guideline is more than enough. Along with that, I want some points to be seen from the NICE guidelines. I did not go through only about this CBT. CBT, and Dr. Adnan was telling some good points, right? I think he was telling from NICE guidelines, right, Dr. Adnan, this talkative therapy.
Yes, that is in the right. Yeah, nice guideline.
Yeah. These things we have to add from the NICE guidelines along with this, what I read now. See how these guidelines help you. One is you got the points, what you will get in the anorexia nervosa, okay, especially this BMI. Then the other thing is, I told you, don't forget about the weight loss, causes of the weight loss. Screen for that in your history, okay. You can ask for the family history, because here celiac disease and also Addison's and some diabetes can run in family, okay. And also when you are asking the systemic review, ask about the neck. Don't forget any neck swelling. She's a girl, 13 years old, hyperthyroidism has to be ruled out. So when we are going systemic review from head to toe, she asked about behavior, where I gave her about the self-harm. Then she asked about abnormal movements and headache, I told. But when after your head and ENT, ask for the neck. In this case, don't forget for any neck swelling for the thyroid, okay. Because in your mind you should rule out hyperthyroidism, diabetes, Addison's disease, all as the endocrinal. And for the inflammatory bowel disease, you will be asking any loose motions, any constipation, all these things you ask, right?
Fatima,
Mm.
he's losing weight, but he's fatigued, right?
Who?
So one point is going for hyper, one is going for hypo.
Who is putting weight?
The hypo one will put the vein
Yeah,
weight,
so here we will go for the hyper, right?
but there is a fatigue. In hyper, the child is active.
Yeah, this will support your diagnosis that this is not. And also you will ask for the cold and heat intolerance when you are asking.
And neck swelling.
Yes.
and even the oral intake, as we can see, hyper, there will be a lot of oral intake, and in this child is not eating anything. That will also support.
Yeah, that will also support. You should negate your this. So bedside, see, always make yourself organized. When you're presenting, after giving the summary, you will give the differential diagnosis. At least keep for 3 differential diagnoses, okay? Why I am giving you the cases, but after we finish several number of cases, then we will do surprise history among these cases, okay? You will not be given from the beginning. Okay.
Can chronic fatigue syndrome also be added to a differential, right?
There is no weight loss in chronic fatigue
There is
syndrome.
no significant weight loss like this, right?
Okay, only that tiredness and decreased activity will go into it, right? Okay, fine.
Yeah.
Diagnostic criteria, what you said, Dr. Nur Fatima. Diagnostic criteria for diagnostic criteria for chronic
One
fatigue
is
syndrome.
the weight, one is the acute weight loss. With this, I told you the BMI should be less than 85% of medium for age. Less than 85% of medium BMI for age and gender. You should know, you will have the table for that. I don't think they will ask you for particular patient giving this calculate there. No, they just need you to remember this thing. This is what I feel. If they ask you what is the criteria for the anorexia nervosa, okay? This is one thing. And another thing, she is thin, but still she thinks that she's gaining weight and she wants to lose weight, always thinking about their weight. And also they have some other problems like anxiety, depression, compulsory exercising, feeling hopelessness. social withdrawal, they don't want to be with people, they prefer to be alone, hair loss, irregular heartbeat, that is sometimes they may have bradycardia. And what else arrhythmias you see in these patients?
Heart block or bradyarrhythmia.
Long QT syndrome can
QT,
also
yeah.
have long QT syndrome.
They can go in for the long QT.
Because of electrolyte
Yes, they
depletion.
can go in long QT syndrome.
Yeah, because
Okay.
of electrolyte depletion.
Yeah, so ECG monitoring is important when you're telling in investigations. Okay, they may have hypokalemia. See here what he has given. If there is vomiting and laxative use, they may go into hypokalemia, right? So all the ECG monitoring is important. So I think we will end the meeting now. Okay?
Dr. Fatima, you are ending now?
Yes.
Okay.
You want to continue?
No. I want to discuss some other topic.
Okay, I will make you host and continue.
No, if you are there for 5 minutes, I will continue. Otherwise,
No, you continue. I will be listening, but I have to go for the duty. So I can listen only.
there is
You are-
Excel course in Kolkata, right?
You are doing for all.
Yeah, as I
Wait 1 minute. I will 1 minute, wait. I will stop this screen share and then I will stop this.